So case 2, okay, it gets slightly more tricky here. So atrial fibrillation, so we should all be up to steam now. He had GI bleeding 5 years ago, okay, and no obvious cause was found. He was topped and tailed. 5 years ago you wouldn't get a capsule endoscopy unless you were still bleeding away, so you wouldn't have had a capsule endoscopy. He's diabetic, he's hypertensive, and his age is over 75. Okay, so he is a patient who's presented to you, and you have to make a decision. So the question is, on your pads you go, what are you going to do to him? There are 5 choices, and I think we've covered those choices. We've mentioned left atrial appendage closure with a, let's say, 5% complication risk and a limited number of shapes of devices to put in. Remember, just like your nose is different from the person sitting next to you, your left atrial appendage is also a different shape, okay? And so there are a limited set of devices that we can put into there to even close that off if we had the technology and the skills to do it. Okay, so let's see what the answer is. Okay, so basically it is warfarin therapy, and the warfarin therapy certainly is what would be required by the CHAD score, and we will obviously be taking the punt on what the bleeding risk actually is. Okay, so the CHAD score suggests that there's an annual risk of about 6% of stroke, and so anticoagulation certainly has to be a very legitimate option. The question is, what is the bleeding risk? We're very good now with CHAD scores and CHAD-VASc, we're increasingly getting used to it. What we're not so used to is actually formally calculating what his bleeding risk might actually be on warfarin therapy. And so there's a number of different bleeding risk scores. I've just picked a couple to show you. They're all available on PDAs and things now. So this particular one from Aspinall, if you're over 65, that's a point. A history of GI bleeding, that's a point. And comorbidity, which includes diabetes, is a point. And he gets into the high-risk category. So he's got a probably 10% annual risk of having a significant GI bleed. So with a score in our head, suddenly it becomes a slightly more balanced decision, whereas with the previous slide we would have been very happy to give warfarin therapy. I think we need to temper that slightly, and we need to really look into why he had this GI bleed, and also counsel him that it might actually happen again. My temptation would be to say that you could still offer him the warfarin therapy, but here is a person who otherwise is generally well, where you might consider an alternative to warfarin. We do know that 17% of patients have a potential contraindication to warfarin. He's got a potential contraindication to warfarin, and even when it does get into the system, it's often stopped again. Okay, and so the people who have high thromboembolic risk often also have the comorbidities, which also make anticoagulants higher risk for them. So it's not an easy decision, and again, we don't have a Premier League solution to it. This was briefly mentioned, left atrial appendage closure, and it's a legitimate option to discuss with them if you have a service that can offer it locally. We're fortunate enough to have one, so we can offer it. But there is a trial behind this. The primary endpoint of this trial was a safety and efficacy endpoint. The safety endpoint was met and the efficacy endpoint was more than met, and this trial that was trying to look at equivalence between a plug in the appendage and warfarin therapy actually came out suggesting not only was it equivalent, it might even be slightly better to have left atrial appendage closure. So a legitimate option to discuss when the bleeding risk is high and the embolic risk is high. Would I at 42 have an appendage closure? Well, no, my CHAD score is low. Would I at 42 have an appendage closure if my CHAD score was 6? Well, yes, I would, because I really don't want to take warfarin therapy for the rest of my life. So it's an option which I think will become increasingly available. Okay, so this chap would end up on warfarin therapy, I think, and take a chance on bleeding, and we'd have a discussion about appendage closure. And when he had his next bleed, I think we'd then switch him over to appendage closure.